Below is a comprehensive, in-depth academic-style explanation suitable for nursing, medical, or research-level submission. Staher Systemic Lupus Erythematosus. 1. Introduction. Systemic lupus erythematosus, SLE, is a chronic autoimmune and inflammatory disorder that affects multiple organs and systems of the human body. The hallmark of the disease is the body's immune system losing its ability to differentiate between self and non-self, resulting in the production of autoantibodies that attack the body's own tissues. The condition follows a relapsing remitting pattern with periods of flare-ups and remissions. SLE is considered one of the great imitators because it can mimic many other diseases due to its diverse manifestations, ranging from mild dermatologic symptoms to life-threatening organ involvement, such as lupus nephritis or central nervous system lupus. 2. Definition. Systemic lupus erythematosus, SLE, is defined as a chronic, multi-system autoimmune disease characterized by the production of autoantibodies against nuclear and cytoplasmic antigens, leading to widespread inflammation, immune complex deposition, and tissue destruction in various organs, including the skin, joints, kidneys, heart, lungs, and brain. Definition based on the American College of Rheumatology, 2023. 3. Etymology. The term lupus is derived from the Latin word meaning wolf. Medieval physicians used the term to describe the facial rash resembling a wolf's bite or markings. The word erythematosus comes from the Greek erythros, meaning red, reflecting the reddish rash associated with the disease. Thus, lupus erythematosus literally means red wolf, referring to the facial lesions that resemble a wolf-like appearance. 4. Epidemiology. SLE is a global health problem with variable prevalence, depending on genetic, ethnic, and environmental factors. Global prevalence, 20 to 150 cases per 100,000 population. Gender distribution. 90% of cases occur in females, particularly during reproductive years, ages 15 to 45. Ethnic predisposition, higher prevalence and severity among African, Hispanic, Native American, and Asian populations. Geographic variation. More common in urban and industrialized areas. Mortality. Advances in treatment have improved survival rates to over 90% at 10 years post-diagnosis, but complications remain a major cause of morbidity and mortality. 5. Types of lupus. Lupus is classified into several forms based on the extent and site of involvement. 1. Systemic lupus erythematosus, SLE, the most common and severe form, affects multiple organ systems such as skin, kidneys, joints, and the central nervous system. 2. Cutaneous lupus erythematosus, CLE, limited to the skin, often presenting as discoid lupus, chronic scaly, red plaques, or subacute cutaneous lupus. 3. Drug-induced lupus erythematosus, caused by certain medications, e.g. hydralazine, procainamide, isoniazid. Symptoms mimic SLE but are usually reversible upon discontinuation of the drug. 4. Neonatal lupus erythematosus occurs in newborns due to transplacental passage of maternal autoantibodies, anti-Rho SSA, anti-La SSB. Symptoms usually resolve within months. 6. Causes. The exact cause of SLE remains unclear, but it is believed to arise from a multifactorial interplay of genetic, environmental, hormonal, and immunological factors. Genetic factors linked to HLA-DR2, HLA-DR3, and complement deficiencies C1q, C2, C4. Environmental triggers, ultraviolet light exposure, infections, e.g. Epstein-Barr virus, smoking, and certain medications. Hormonal influences. The predominance of SLE in women of childbearing age suggests estrogen contributes to immune dysregulation. Immunologic abnormalities. Overproduction of autoantibodies, anti-dsDNA, anti-RMP, and defective clearance of apoptotic cells lead to immune complex deposition and chronic inflammation. 7. Risk factors. Female gender, especially during reproductive years, family history of autoimmune diseases, ethnicity, African, Asian, Hispanic descent, sunlight exposure, UV radiation, certain drugs, hydralazine, isoniazid, procainamide, smoking and exposure to environmental toxins, stress and viral infections. 8. Complications. SLE can lead to serious, life-threatening complications if not properly managed. Renal, lupus nephritis leading to chronic kidney disease or renal failure. Cardiovascular, pericarditis, myocarditis, accelerated atherosclerosis, hypertension. Pulmonary, pleurisy, pulmonary embolism, pulmonary hypertension. Neurological, seizures, psychosis, stroke, cognitive dysfunction. Hematologic, anemia, thrombocytopenia, leukopenia. Pregnancy-related, recurrent miscarriage, preterm birth, preeclampsia. Infectious, increased susceptibility due to immunosuppressive therapy. 9. Pathophysiology SLE is initiated by loss of immune tolerance leading to the generation of autoantibodies directed against nuclear components, e.g. DNA histones. 1. Autoantibody formation. B cells produce autoantibodies that form immune complexes with nuclear antigens. 2. Immune complex deposition. These complexes deposit in tissues, e.g. kidneys, skin, joints. 3. Complement activation leads to inflammation and recruitment of immune cells, neutrophils, macrophages. 4. Tissue damage. Chronic inflammation causes fibrosis, necrosis, and permanent organ damage. 5. Cytokine imbalance. Increased levels of interferon I and TNFi sustain autoimmunity. Number 10. Stages. SLE progresses through several stages. 1. Asymptomatic preclinical stage. Presence of autoantibodies without symptoms. 2. Early symptomatic stage. Mild symptoms like fatigue, arthralgia, and rashes. 3. Active flare stage. Severe inflammation with multi-organ involvement. 4. Remission stage. Symptom-free period due to effective treatment. 5. Chronic stage. Repeated flares lead to irreversible organ damage. Number 11. Signs and symptoms. General. Fatigue, fever, weight loss. Skin. Malar rash, butterfly rash, discoid lesions, photosensitivity. Musculoskeletal. Arthralgia, arthritis, non-erosive. Renal. Proteinuria, hematuria, edema. Cardiac. Pericarditis, chest pain. Pulmonary pleuritic pain, dyspnea. Neurological. Seizures, psychosis, depression. Hematological. Anemia, thrombocytopenia, leukopenia. Gastrointestinal. Nausea, abdominal pain. Reproductive, menstrual irregularities, pregnancy loss. Number 12. Medical diagnosis. Diagnosis is based on clinical evaluation and laboratory investigations. Immunologic tests, ANA antinuclear antibody, positive in 95% of patients. Anti-dsDNA and anti-SM antibodies, specific for SLE. Antiphospholipid antibodies. Low complement, C3-C4. General tests, CBC, anemia, leukopenia. ESR, CRP, inflammatory markers. Urinalysis, proteinuria, hematuria. Kidney or skin biopsy to assess tissue involvement. Classification criteria based on EULAR-ACR 2019 criteria, which require a positive ANA and a weighted scoring system of clinical and immunologic findings. Number 13. Nursing diagnosis. 1. Fatigue related to chronic inflammatory process. 2. Acute pain related to joint inflammation. 3. Impaired skin integrity related to photosensitivity and rash. 4. Risk for infection related to immunosuppressive therapy. 5. Disturbed body image related to disease manifestations. 6. Deficient knowledge regarding disease process and treatment. Number 14. Medical management. Corticosteroids, prednisone for acute inflammation. NSAIDs for mild joint pain and fever. Antimalarials, hydroxychloroquine for cutaneous and joint manifestations. Immunosuppressive drugs, azathioprine, methotrexate, mycophenolate mofetil, cyclophosphamide. Biologic therapy, belimumab, B-cell inhibitor, rituximab. Plasmapheresis for severe refractory lupus. Anticoagulants in antiphospholipid syndrome to prevent thrombosis. 15. Nursing management. Monitor vital signs, renal function, and disease progression. Maintain fluid and electrolyte balance. Encourage rest during flares and gradual exercise in remission. Promote skin protection. Avoid sunlight. Use SPF 30. Educate patient on medication adherence and early signs of flare. Provide emotional and psychological support. Monitor for side effects of corticosteroids, e.g. weight gain, osteoporosis. Encourage a balanced diet rich in calcium and vitamin D. Number 16. Treatment options. Pharmacologic treatment, as above. Non-pharmacologic measures. Regular exercise and stress management. Smoking cessation. Diet modification. Low salt, high calcium omega-3 fatty acids. Physical therapy for mobility. Surgical treatment. Rare. May involve kidney transplantation and lupus nephritis. Number 17. Psychosocial interventions. 1. Individual counseling. Helps patients cope with chronic illness. 2. Support groups. Provide emotional comfort and shared experiences. 3. Cognitive behavioral therapy, CBT, manages anxiety and depression. 4. Family therapy. Encourages family involvement and understanding. 5. Vocational rehabilitation. Assists in workplace adjustments and maintaining employment. Number 18. Prevention. Though SLE cannot be completely prevented, flares and disease progression can be minimized by avoiding direct sun exposure and using sunscreen, maintaining medication adherence, managing stress and ensuring adequate sleep, avoiding smoking and alcohol, routine medical checkups for early detection of complications, proper vaccination to prevent infections. 19. Conclusion. Systemic lupus erythematosus, SLE, is a complex autoimmune disease with diverse clinical manifestations that can significantly impact quality of life. Early recognition, prompt treatment, patient education, and multidisciplinary care are essential to control disease activity and prevent long-term complications. With advances in immunology and biologic therapy, the prognosis of SLE has greatly improved, allowing many patients to lead fulfilling. Thank you. Have a nice day.